I guess a third thing is giving the client, regardless of their age, I know the example you gave was a 12-year-old, like agency. So there's something we use in our hospital, voicing my choices. And it's
I love
just
that.
a,
Placing my choices.
yeah, have you heard of it?
No, but it makes perfect sense.
So it's basically like this guided, there's like questions. And these are questions that we would a lot of times ask adults, like, do you want to be cremated, things like that. But it's guided questions that you can do with kids so they feel agency over their care. So
Right.
it can be things like they want certain medical interventions. These are the people that they want around them when they die.
Well, welcome all to the next episode of Brain Hope Reality. What makes this particular episode unique? We have a very special guest, Jess Rabon. I met her on her podcast, and she was kind enough to accept my invitation. So thank you.
Thank you.
This is the first podcast from Mexico. We have a home in Mexico in San Miguel Allende. Today is Day of the Dead. So it's celebrated. This is my custom made shirt brought to me by me. This is what I look like last year. This time I'm going to have a whole new makeup done today. I cannot wait.
I
This
love
is
it.
part of the costume, the hat. You have to have a hat, of course.
Hmm.
Anyway, so today I thought we can talk about a couple of things. Positive way of looking at death and dying, which is sounds like a very morbid
Hmm.
thing, but doesn't have necessarily morbid. It's the reality of life. I have little insight on that, having been almost killed by a propeller blade and having been in the tunnel from out of body experience. Jess has a lot of experience with death and dying in pediatric hospital,
Hmm.
and Kubler-Ross has done an amazing way of looking at that. I thought we can talk about it. We can also talk about pediatric PTSD. Anyway,
Awesome.
just a few things. This is loose in ideas to keep it as light as possible. It is a pretty grim subject. Anyway, welcome aboard, Jess.
Well, thank you so much for having me. I'm excited to connect with you again over podcasting.
Thanks for having me. I'm excited to talk. I think we had a great conversation last time. Why don't we get in it, if you don't mind? So, one of my
Absolutely.
basic view of the word, and if you ask my wife, she'll probably tell you that true. The most crazy stuff that I've gone through and will go through, the best way to deal with is humor. Something light.
Hmm.
Even the worst situation, you can try to find humor in it. Sometimes you have to dig pretty hard. So
Hmm.
if you think about Mexican culture and Day of the Dead, I think they've embraced it. They're not embracing death; they're embracing life and celebration of people who were alive, who were relevant or
Hmm.
meaningful to them. So we have an altar downstairs, for example, that has pictures of our dead dogs, a stuffed toy that my mother had before she died, and so on. And it kind of feels it's a day of remembrance, but in a very positive way. That's how I look at it. So I'm
Hmm.
curious to see some of the strategies you use in your practice. Maybe you can talk about your background and what you do currently, and why do you have to deal with death and dying.
Absolutely. Thank you for asking. So, I am a clinical psychologist. I have my PhD in clinical psychology, but I work in a children's hospital, working as a pediatric psychologist. So, 50% of my time is medical inpatient. So, I'll get to that when we talk about death and dying. And then the other 50% is outpatient in our adolescent medicine clinic, where I'm doing more traditional psychotherapy. But in the hospital, people think psychologist, hospital, it must be psychiatric. Yes, I see psychiatric issues, but mostly I'm working with children and adolescents with chronic illnesses, those who have been in significant traumas like car accidents, gunshot wounds, new diagnosis of a medical illness. I do see a lot of eating disorders. That's probably the most like stereotypical mental health concern. But to your question about like, why do I have to deal with death and dying? I work with a lot of kids that have terminal illnesses. I going back to the accidents, car accidents, gunshot wounds, a lot of times when I get involved, they are going to survive. But I actually sit on our pediatric palliative care team. So even if I'm not directly involved in patient care because it's more of an end of life discussion, I'm part of a team that the medical providers are involved in those discussions. So unfortunately, I do see a lot of death and dying. I've had a number of patients die over the years, which is something I feel like when you get your doctorate in clinical psychology, we're not necessarily prepared for because many people go on to work in like private practice or things like that.
Happy,
But yeah,
happy.
happy, exactly. But I love the work I do. I think we touched on this a little bit when you were on my podcast, but I love the integrative approach. I love working with physicians. I love working with child life PTs, speech therapists, dietitians. So I wouldn't trade it. But yeah, with death and dying, it's not only, working with the patients on, you know, identifying their goals for end of life care, but also the families, siblings, helping them prepare for
So let me ask you a
that.
question. So
Mhm.
what brought you to be interested in that? You could have had that type of light, fluffy psychiatric practice or psychological
So
practice.
so people ask me this all the time, and it's funny in the sense that, like, ironic, I don't really know. So I got my PhD because I thought I wanted to do research. Like 100% thought I was going to go into academia, had no interest really in doing clinical practice. And then obviously when you get your PhD in clinical psychology, you have to do clinical practice. And so I always said, and I don't know where I got this from, like if I had to do clinical work, I would want it to be in like a medical type setting. It just was more interesting to me in the sense of I've always really been a big proponent of like the integration of physical health and mental health. It's something I've always done in my personal life. Really value moving my body, exercise. I played sports growing up, things like that. And so the PhD program I went to was integrated primary care focus. So I had to take classes with medical students, nursing students, public health students, had to take health psychology courses. And then my first clinical rotation, I did a children and adolescent rotation because nobody else in my cohort wanted to do it. And I was like,
Right? It's hard.
I'm going into academia. It doesn't matter. Sure, I'll work with kids. And I fell in love with it. And so while I was there, I worked in a primary care setting. When I applied to internship, and I don't know how familiar your listeners are, but the way I describe this to individuals is our internship is the last year of a PhD program. And it's similar to a medical residency in the sense of you have to apply to a bunch of different places across the country. You go to interviews, you go through the same match
It's
process,
intense.
and then you have to go wherever you match to.
Yeah, right. Yeah.
Um, except ours is only 1 year, and then it's the last thing we have to do before we get our doctorate. And so I only applied to hospitals when I did that, and then I did my fellowship at a hospital, and then they hired me on, and I've been there ever since. So all of that to say, I don't really, other than like liking it, I don't really know like why I had this deep desire to work in a hospital, but I did, and I love it.
We don't need to analyze it. So, well, I'll tell you where my particular interest in death and dying comes from.
Hmm.
So, one, I've been a trauma surgeon for 2 years. So I've seen plenty of death and dying.
Hmm.
My mother took her life when I was an intern. So that actually gave me a very specific purpose, trying to help, especially women,
Hmm.
with psychiatric disorders. And she killed herself. So psychiatric disorders to me are really not ha 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 little things. That could be deadly.
Yeah,
And everybody
absolutely.
knows that, but it's like, until it's personal, it's not. So it's funny. So 2 days ago, I had a piece in USA Today.
I saw that.
Oh, thank you. So that was a good piece. So I sent to one of my friends, and she said the best quote from there was that, and which is a true quote. Whenever I hear somebody getting better after a procedure, I feel like my mother is giving me a tap in the back, saying you've done a good job with something which was pretty rough.
Yeah.
Anyway, so that's kind of my perspective. And I also had an out of body experience in Mexico when I got hit by a propeller blade, lost half my blood volume in about 10 minutes, and I was in the tunnel. And after that, I've lost my fear of death because it was really an amazing place to be. Anyway, having said that, I do have a couple of specific questions for you. With
Okay.
your background, I think you're perfectly suited.
Okay.
So,
Hopefully.
when you talk to let's say, a 12-year-old child that has
Mhm.
terminal cancer, they're going to
Yep.
die. No, no question. It's like it's a sarcoma. Let's say it's horrible,
Mhm.
horrible, horrible. We don't have to get details.
Yep.
What is the between 2 to 5 best strategies do you give them to stay themselves calm? What is your methodology? I'm just trying to learn.
Yeah.
I don't know much about this because
Yeah.
I do my thing and I walk away and I go, psychologists do that, whatever that they do.
Mhm.
Anyway,
Yeah.
this is what you're doing. So 2 to 5, I think, things you've learned in your extensive experience.
Yeah. Okay. So I think the first thing that I do, and I think is probably the most important, is assessing their understanding of what the medical team is communicating to them. Because as you know, getting a terminal diagnosis can be extremely overwhelming. And the medical team can be like, yeah, we talked to them, they understand. And then I can go in the next day or a few hours later and ask about like how the conversation went, what's their understanding. And maybe they get bits and pieces, but
Push
they
on
don't.
that so I
Yeah.
understand what you're saying. Are you saying, are you trying to, because there are two things people can don't understand. One, when somebody says you have a terminal cancer, and they go, you know, doctors will fix it. And then once the team is going to say we're going to do some ecological intervention, chemotherapy, radiation, whatever. That's one aspect. So being able to predict what's going to happen to you, that's one. The other part,
Mhm.
you're going to die. I
Yeah.
mean, you're not going to be around. It's time to put your affairs in order. Yeah, either both or one or which ones.
So I'm assessing for all of it. What I will say is sometimes it is the first in the sense that they may not fully understand the language, like what does terminal mean, things like that. I, I have seen the second, and the reason I ask this question is because a lot of times I have encountered where it has been explicitly laid out for them. You are going to die. There's nothing else we can do. And they're avoiding like that, denying. And I guess this is already kind of going into the
Overall,
stages of grief. Yeah. But
we
like
can say
denying,
your answer if you like.
yeah,
Whatever.
denying that it's the reality. So I
If you
need
don't
to,
mind, Jess, I'm sorry about that.
yeah, no.
For most people have never heard exactly what those stages of death and dying of Kubler-Ross. If you don't mind, just quickly talking about that so people understand.
Oh, yeah, absolutely. So, denial, and we talk about stages. There's 5
Right, right.
stages, but they are not like, stepwise in order except to the last one, but they're denial, anger, bargaining, depression, acceptance. So the first stage is denial. And I would argue that a lot of times that is probably the first reaction I see. I also see a lot of anger. And then you can go back and forth with these stages. You might be in denial, then you're angry and depressed about it, but then you might be bargaining, but then you might be angry again. So you can go back and forth. And then acceptance is obviously you have accepted whatever this reality is. So that's a brief overview. Do you want to add anything to
I
that?
think that's exactly right. But, I think one of the things, and this is where the nuance part of it comes in, is this is a defense mechanism. When
Mhm.
somebody says you're going
Absolutely.
to die, say, "Oh, I think you're wrong. I want a second opinion." Or you can go, you get pissed off. So if you get
Mhm.
angry, you don't have room for sadness. You're like angry.
Yeah.
Then you go, okay, so how about if I have my cigarettes, maybe I'll live. That's bargaining. That's now the question is who are you bargaining with exactly? Typically,
Mhm.
it's a higher power,
Yep.
right? And acceptance is obvious.
Mhm.
And then, yeah, I mean, basically, and so the question is when they're in denial and they don't want to hear about it, how
Mhm.
far do you want to push on that? And that's where the nuances all come in.
Yes. And so I guess that brings me into the second thing I've learned is really having to meet the clients where they are. And this applies to anything, but especially when it comes to something like end of life. A lot of times my sessions really focused on end of life or goal setting or things they want to accomplish are much shorter compared to other topics that we might talk about because they can only tolerate so much, especially when it comes to their own mortality. I guess a third thing is giving the client, regardless of their age, I know the example you gave was a 12-year-old, like agency. So there's something we use in our hospital, voicing my choices. And
I love
it's
that.
just,
Wasting my choices.
yeah, have you heard of it?
No, but it makes perfect sense.
So it's basically like this guided, there's like questions, And these are questions that we would a lot of times ask adults, like, do you want to be cremated, things like that. But it's guided questions that you can do with kids, and they're obviously done in a developmentally appropriate way, so they feel agency over their care. So it can be things like, yeah, they want certain medical interventions. These are the people that they want around them when they die. Even certain things like I've done with, you know, patients about like, what are your favorite colors or flowers or things? So like when people celebrate your life, going to what we were talking about, the positives, like they still feel like they have some agency over, the color of the balloons at their funeral, or, if they want to do, I don't know, a what are those called? Lantern send off. I know those aren't super environmentally friendly, or if they want a tree planted or things like that. At what point do they want no more medical intervention? And obviously, it's easier when they're like 12 or adolescents than if you're asking like a 6-year old, but there still are adaptive ways to do that. Um,
No,
and I
I
mean,
think
and then,
it makes a lot
yeah.
tremendous.
And then I would also say, like, just the standard quote unquote like coping skills, like deep breathing, boundary setting. I do a lot of self advocacy work because it can be really hard for a 12-year-old to speak up to a physician. Like they're my doctor, but like teaching them, you know you can speak up when you're in pain, or if you don't want that medication anymore, like giving them the skills to do that.
Here's a big question I'm interested in.
Yeah.
How do they speak? Because the parents are grieving already, right?
Hmm.
And how do you teach a 12-year-old, let's say, to tell the parents, hey, knock it off, it's about me, not about you right now? How do you do
Yes.
that? That's a tough one.
So the first step I usually tell my young patients is, if they don't feel comfortable speaking up to their parents, you can make the medical team the bad guys, and we're happy to speak up for you. So, like a lot of times, and this doesn't have to be end of life, but a lot of times, if a patient discloses to me, like, oh, my parents are doing this and it's really frustrating, I'm like, do you want me to bring it up to them? And I'll take the parents outside, and I won't be like, your child said this, but I'll be like, children in your or children that have similar issues or diagnosis to your child often like X, Y, and Z. So, how about we try this? Another thing I appreciate about working on our palliative team is our MDs do a lot of that supportive care for the parents. A lot of times we'll coordinate. So, like when I'm working with the kid, the physician is working with the parent on strategies, and obviously we're coordinating ahead of time, like these are the things we need to work on.
Let me tell you a little step to the side, but it's kind of interesting. Talking about agency, right?
Hmm.
So I treat PTSD, which I think in
Yes.
children, like we talked about. So one of the things, we had this patient that came in to see me when he was 9 years old. First time he arrives there, he hides, can't find him. So the parents said, where are they? Finally find 2 hours later. I said, he doesn't want to have it done. We're not forcing him. We're not
Yeah.
sending him to the table. Goes away, comes back a year later, hides in a towel heater. Find him three
Hmm.
hours later. I was like, we're not doing it. The
Yeah.
parents came at me. I was like, we're not doing it. I'm not going to do this. We're
Yeah.
not use a child. Comes back 2 years later. Now he's 12. Comes in, and we were going to put him asleep like we always do with kids. Anesthesiologist was late. He said, you know what, doc, I don't need anything. I said, tell me what you want. I don't want numbing anything. I don't want anything. Just do an injection. So the parents are going, no way.
Yeah.
So my nurse is going, no way. I said, I'm going to listen to the patient. We could stop. If there's a problem, we'll stop. Lies down, doesn't move. We do the procedure. Comes out, gives me a high five, doc. I said, 5 minutes later, I feel great, doc. Thanks. Nothing. No local,
Hmm.
no sedation, no IVs, nothing. He said, do I need to get an IV if I'm getting it like this? No. Great, fine. So it looks at
Wow.
me like that. Like,
Yep.
this is somebody who was hiding in a heater for hours, so I didn't do anything to him.
Yeah.
So it's the
But
same concept, right? Listening to the patient. That's what I always
listening to, yeah.
teach my residents, fellows, whoever. It's like, listen. If you listen, your chance is much higher if you don't listen. But that is the best example.
Absolutely. No, I love that example because a lot of times too, I'll obviously have the parents in the room for more serious conversations. And if I notice like the parents are talking for the child, I'll redirect to the child and say, I'm hearing a lot of mom, dad, grandma, whoever the caregiver is, thoughts. I want to hear what you think.
Ooh,
Or
great.
um,
That's great.
because a lot of times, and I will say, I feel like my hospital system does well at talking to the children, but a lot of times physicians will talk to the parents with the children in the room.
Listening quicker.
Yeah. Well, yeah, exactly. Because, you're probably not going to have to explain as much or that you think it's too overwhelming. But, a lot of times will facilitate conversations or even give options if I can tell the child is a little hesitant to speak up. I might say, like, some kids prefer this that their parents do, and some kids prefer this thing. Do you have a preference? And then they can be like, oh, yeah, I think this would be great. I'm like, awesome. Mom, did you hear that? They
You know,
want you to do this.
that is we should do a podcast just on that because a lot of the doctors need to learn that skill. This is very similar to what I'm trying to say. Listen, yours
Yes.
is like 20 levels higher because you
More
can,
explicit.
well, somebody can do this, somebody can do that.
Mhm.
Because that's actually getting an informed consent to a different level. That takes
Absolutely.
longer, but it's much better.
Mhm. Well,
Wow.
and then it goes into going back to your original question of, like, preparing for, like, conversations about, you're gonna die, giving them choices because it can be so overwhelming. Like, "Okay, my physician just told me I'm going to die. Now what?" And it's like, "Okay, well, do you wanna talk about how you're feeling? Do you want to talk about the things you wanna accomplish before that happens?
If
Okay,
there's
we can
yes,
start there."
they ask them, do you want to do something special? Like some kids may want to go to a game and meet somebody or get an autograph
Mhm.
special, something like that.
Yeah, so sometimes we'll do that. I think it a lot of times depends on how long they are predicted to, live. I know our hematology oncology department, will try to do, like, little what we call little wishes. Actually, everybody in the hospital does it, but I know hemonc does it a lot. So, if they can't do, like, a whole Make-A-Wish, like, is there a smaller wish that can be fulfilled?
We could have
Um,
more achievable, is what you're saying.
yeah, and even things like, do you wanna die in a hospital? Do you wanna die at home? If that were to like, if we
Yeah.
have the choice. We do have, like, one pediatric hospice house, but there's pediatric hospice houses aren't
Oh my God,
super
must be almost
common.
not. Yeah. So let
Yeah.
me ask you this question: what do you think? So last stage of Kubler Ross
Mhm.
is acceptance. Is
Mhm.
that a particular methodology used that seems to lead to that more than other approaches?
I wouldn't say a particular methodology. Um, I will say reflecting on the patients I have had who have died, and I feel like they truly got to that stage. It's more of the things I've been talking about in the sense of, like, giving the patient a voice, providing psychoeducation to the parents of needing to listen to their child. Like, 2 kids, I guess, well, one was he was 11, the other one was a teenager, but the 2 that stick out to me the most are the ones who we worked really hard with on finding their voice, voicing their choices of when they were ready to pass. For example, one girl that I'm thinking of, she was actually my first patient that ever died. Had pretty severe cystic fibrosis. Cystic fibrosis treatment, though, has
It's much better.
become, oh my gosh. I
It's
used when I
next.
started working, yeah, so I've been working in the same hospital for about 7.5 years. When I first started working, I would have a cystic fibrosis patient on my caseload pretty much all the time. Maybe I see 1 a year now because treatment has gotten so much better. So this was, like, a while ago, and, it was getting to the point of a lung transplant, and she was like, "I don't want it. I don't." She was like, "I have lived a full life." She was 17 when she died.
That's a rough. I mean, before they die, I've done lung transplants on those guys.
Mhm.
They love their last couple of years is rough. They can't breathe.
Yeah. Exactly, and I mean, she was in the hospital, but She graduated with her GED. Like she accomplished things that she wanted to do, and like the parents, mom in particular is who I remember. She was like, "I want this for her, but if she does not want this, like if she's been struggling and does not think this is the choice for her." And it took mom a long time
Yeah.
to get there, obviously.
Basically, it's empowerment. But the other thing is that, I mean, not that it's a good thing. It's a slow process, so they have
Yeah.
time to get used to it.
Yeah.
Anyway, if you don't mind, that's pretty morbid, even though
Yeah.
today we'll do that. So I thought one of the we could talk about uh, using humor as
Mhm.
treatment modality for PTSD.
Okay.
So just to start it off, as you can see, I have my gear. And then I'm really getting into AI art. I'll show you some examples and we'll post some pictures of it. But what I find is the way I sign my art pieces now is, and actually I sold 2 pieces in Mexico, believe it or not.
Congratulations.
Thank you. Anyway, I signed it AI slash my signature.
Okay.
It's generated by that and I augmented a bit. But I read an article that shows that humor reduces amygdala function or
Okay.
reduces amygdala overactivation, which is seen in
Overactivation.
morbid humor, like gallows humor,
Mhm.
uh, does the least. So light,
Interesting.
pleasant, beautiful things, happy things. So I'm curious to see how you use humor in
Mhm.
your job. I'll tell you some of my examples, but I'm curious to see yours.
Yeah, so, I mean, in the hospital, I obviously see all ages, but I work in the adolescent medicine clinic, so I primarily see teenagers, and I feel like humor about anything mental health and trauma is their, like, go-to.
What's your
So,
the funniest joke you've heard so far, or funniest statement? Doesn't have to be a full joke.
um so
Anything.
this is yeah, the first thing that came to mind, which isn't it's good because it's not even morbid. It was a
Roy will be
patient
very happy with you. It's okay. You don't
no,
need
it was a patient in the hospital and chronic migraines, rumination syndrome, like just all physical health did not feel good. And I was trying to come up with coping skills and background. Kid had a learning disability in reading. Okay, you need to know that for the joke. And we were talking about things you can do in the hospital, like video games, things like that, but migraine screen. And I was like, have you tried reading at all? And he deadpan looks at me and goes, I can't read anyways. And I was like, sir.
Oops.
And I was like, but that was really funny. And I was like,
But then,
yes.
I've said that once before. I was actually, I got myself in trouble once in a trauma unit, kind of not, it wasn't, I didn't perceive it as funny at the time, but the
Yeah.
patient did. So there was a patient that was lying on a table and he had a chest wound. Somebody shot him in the chest. So we put
Mhm.
a chest tube in, all the usual stuff. And all I saw was his chest.
Yeah.
And he was like 45 years old. And I said, "Oh, don't worry, we'll pull out the chest tube. You're running anytime." He said, "Doug, I'm missing a leg." I was like, I'm very sorry. He said, "That's okay, Doug. I'll get a peg." I was like, whew.
The deadpan humor
Yeah.
I love.
But I'll tell you one of my other, I use humor to explain complex physiology sometimes. I'll give you an example.
Mhm.
So I saw a video of his name was Luke. He was a special forces guy, steps in the mine, almost blows off his leg. I always have happy stories. Anyway, so somebody else, not me, did a stellate on him, and he did much better. So you could see them before and after. So at the end, his wife says, "Oh, he's so loving. He was so terrible after he came back from the war." And the guy says, "Yeah, yeah, yeah. I sleep. My nightmares are gone. But basically, I like being laid. So now my equipment works. I'm 32. I should be able to." So that I had a chapter about this. So when I talk to the men now, turns out up to 85% of men have sexual dysfunction following PTSD. And there's a whole norepinephrine curve and all this
Yeah.
complex neurobiology. Why is that work? So when I explained it, I don't talk about any of that. I go, if you want to read the chapter, go read the chapter. But I said, think about this. If you're running from the tiger, you want nothing sticking out.
Mhm.
And they go, okay, we understand that. Right now, my body thinks I'm running from the tiger. Nothing's going to
Yeah,
work. When I stop running, the equipment will work.
will
They'll
work.
stick out. I said, you understand the principle. There you go. There's the
I love
principle.
it.
You
Yeah.
don't need to know more detail, norepinephrine, all the, blah, 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 blood flow. Doesn't matter.
Yeah. No, absolutely.
I
No,
love
I
those.
think humor is a great coping skill in general, because like, when we're talking about hard things, you need to I find at least that humor is a way that we can talk about difficult things without it being as hard to talk about, if that makes sense, because you're making kind of light of hard things and people are more willing to talk if you're kind of cracking jokes or the deadpan humor, or things like that. And you can kind of get into like, okay, this is something that happened, but we're not diving deep. We're
So
still talking about it.
let me run this idea by you.
Okay.
So, and I'll give you a little background and I'll tell you what I'm thinking. So I took care of a patient that was shot, a 10-year-old kid in line of duty. Comes home, he exploded because it was Iraq. It was, explosive,
Mhm.
whatever. Comes home, tried to kill his wife a few times.
Okay.
So I do the block on him, still a giggly block. So he said, I remember doing it, but it sounds black and white. The emotional part's gone. 10 minutes after the procedure.
Mhm.
The reason that happens is because amygdala remembers emotional memory,
Mhm.
hippocampus remembers regular memory, right?
Memory, yeah.
So you can separate the two. So I think if humor works on amygdala, we know there is fMR
Mhm.
evidence. So if you relax people by reducing the amygdala by being humorous,
Mhm.
everything else doesn't seem as grim. Somebody says, we have to cut off your leg, but you take a joke before that, not about the leg,
Mhm.
obviously.
Yeah.
But I think the acceptance you'll be able to talk to them better.
Mhm.
Not being a fool, not telling some kind of stupid or
Yeah.
hypersexual, but something like that is pretty interesting because I see it. That is kind of my bedside manner, kind of
Mhm.
spunky, funny, direct. Because I learned it in trauma unit, right? I mean, you
Mhm.
don't really have much time. It's like, hey, doc, am I going to make it? It's like, I don't know, maybe. It's like, what? It's like,
Yeah.
you're okay. I usually only say it when people are not almost dead, obviously. It's like, yeah, it's
Yeah.
okay. Like, we're going to take care of you. You're fine. I'm just joking around and go, whoo. But I think that relaxes people. And I think that's about what you were talking about. But if you listen and see the body language, I think, of the person, if you
Mhm.
see them very tense, it's like, you're here, you're okay. Then you can see
Yeah.
the shoulders go down, and then you see that, I'm sure, in the hospital you're in.
Absolutely. Well, and I think what you just said about, like, reading the body language, like, I love humor. A lot of my clients do too, but there's definitely times I, like, know it's not appropriate to use humor. You talking about your bedside manner, one of my things I say quite frequently in the hospital is, when I'm talking about finding a therapist outside of the hospital and things like that, I always talk about, the most important thing is the therapeutic relationship. You need to trust, da da da, give this whole spiel. And then I go, unfortunately, in the hospital, you are stuck with me. So you don't get that option here. But when you leave here, or I'll say, I'm going to come by and check in on you. But if I leave this door and you look at mom and you're like, that crazy lady, I don't want to see her again, that's fine. Just let me know. And so I like to use humor in that way too, to kind of relax the patient because they're in the hospital. The
You're also
hospital's
giving
not
them a
fun.
choice.
Well, yeah, and it goes back to choice, which
You're,
I think
step,
is really important in
you're
my
stepping in their
practice.
shoes, right?
Yeah.
Right.
And so I think,
Consent.
using humor can also make people feel more comfortable
And
as
connect,
well.
right? I mean, it's
Yeah.
connected, and they feel like they can confide in you.
Hmm.
I think those are really cool tricks. I mean, it's interesting how we have fairly different backgrounds, but that
Absolutely. Yeah.
the reality though is pretty similar. Listen to patients,
Hmm.
get them as relaxed as you can, and do what you can.
Hmm.
Um,
Absolutely.
I think it's great. Well, we've done. Usually, I do only 30 minutes. Today went crazy. 42 minutes. Woo!
Crazy.
Crazy, crazy. Um, so, if you don't mind, if you want to have any final last words, I'd love that. I'll send you some of my new art that's coming out.
I
I'll
love
put
that.
some up just for see people. People can see it. It has been extremely relaxing for me using. I usually start with ChatGPT with a concept and you can
Yeah.
adjust it. Then I put it into Photoshop 2025, use AI there. I print it on canvas and then I use metallic paints. And it's been really a joy to do. It's fun.
I love that. I love that. Yeah, I don't think I really have any last thoughts. I think thank you for having me on. This was a really fun conversation. And I guess if I had to summarize, death and dying is hard to talk about, but it doesn't have to be. We can make it, whether that's with humor, with choice, with coping in our own way. We're all going to experience it.
Yeah.
And so,
But the last thing I would put in is just Kubler-Ross perspective. I've
hmm
been using that on everyday life.
hmm oh,
Certain
yeah.
relationships I've been in, which you start, it's like, what? Are you kidding me?
hmm
Denial. Then you get really angry. It's like that's just stupid. What kind of? I mean, why am I even here?
Yeah.
It's like, well, maybe they didn't mean that, right? And
hmm
then just go like, done. Thank you so
Yeah,
much. So this is
absolutely.
something that my wife says sometimes I'm a little too good at, but I think I'm superb at knowing when it's over.
Yeah, I love
So
it.
yeah, so it's like I always tell people like like uh, when somebody's telling me, do you think this is going to happen? Where are we at? How far? I said, the last thing you do when you pronounce somebody, you look at the clock.
hmm
You got to look at the clock.
Yeah.
Over. Thank you very much.
hmm
Over. There's
Yeah.
nothing. There's nothing left to do with over. But knowing the only piece of advice I would give to the listeners is, if you know when it's over, a sharp cut is much better than slow rip of a wound. So
Absolutely.
when you know it's over,
It's over.
do something that's over to realize that, understand it, obviously decide it's the right thing, but then move strongly from that position. I see so many people like dragging on. They're going back and forth to somebody who's abusive to them. You probably have seen similar things.
Yeah.
It's like, speaking of that, so ending a bad relationship, toxic relationship. Do you have two words of advice ending toxic relationship? Mine is aggressive, like it's surgical intervention. It's like, okay, bad relationship is terrible. You identify it. Once you identify it, move on it. But what would be a psychologist's perspective instead of a trauma surgical perspective? Uh-oh. Did you freeze up, buddy? Oh, no. Jesse. Ah, that was a great question. Dang it. My friend, I think I lost you.
Hello.
Hey, buddy. All right. So I'm not sure what occurred. I'll,
So you froze and then left. Can you hear me?
I can hear you. Can you hear me?
Okay. Yeah. It's still recording on my end, so I didn't want to exit.
No, it's good. Exactly. Thank you. All right. So let's see, I had one excellent question. Let's see if I remember what it was. Oh my God. What was my other question? So, what is the last thing we said before we?
We were talking about if you know it's over, it's over. That was
Oh
the
yeah.
last thing I heard before.
So my saying was, I am, my perspective is that of a surgeon, right? It's like,
Mhm.
once make a diagnosis, be sure, measure twice, cut once, but and then when it's over, it's like just go do it over. As psychologists, when somebody is, let's say, in toxic relationship, they're sure it is, the parents agree, their therapists agree. Your top four advices: how do you get out of a toxic relationship? I know one person like that. I'd like to carry that on.
Um, so when I think of toxic relationships, I because it's not my job to tell them to to leave.
I
It's
understand that.
to give them the agency to leave themselves. So
Mine
one
is
thing I'll
goodbye. Goodbye.
yeah, one thing I'll do a lot is like a risk benefit or positive, negative, pro con, whatever you want to list it as. So, what is keeping you staying in the relationship? And identifying what are the negative things about the relationship? What are the barriers to leaving? Because a lot of times I have found that the fear of the unknown is a lot worse than staying in a known situation that is poor for you because you know what to expect,
You mean
even though you know it's bad
the
for you.
you mean
The
the
talks are
devil the devil basically.
exactly. So you know it's bad for you, but you don't know if you were to leave, what could come. Because people tell me all the time, well, yeah, something better could come, but something worse could come as well. And I think it goes back to like the agency that we talked about earlier, uh, helping people find their voice, find their self confidence. Because a lot of times people will stay in toxic relationships because they're not confident enough to know their worth or
Okay.
things like that.
And the last question is, um, certain people, which I know a lot of people like that, only are attracted to crazy women. What do you think the cause of that is? And the same
Okay,
goes
this
both
is,
ways, but I'm just talking about I happen to know men who are attracted to crazy women.
yeah. So this is not based in any research. This is just my gut instinct. Um, People like adventure, and some people like unpredictability, and that can come in relationships. Um, and maybe you don't know the level of crazy before then.
A little crazy is good. A lot crazy is scary. Is that what you're saying?
It can be. I mean, for anybody, um, you know, there's everything in moderation.
I agree. You know, I've been in a crazy level.
Yeah,
Oh my God. That was like, whoa, that scared me completely to death. Anyway, okay. Well, thank you. I'd like to thank you again. I'm sorry. It's one of the downsides of being in Mexico. Occasionally, the Wi-Fi is not so good.
no, no problem.
So it's an absolute pleasure. Let's stay in touch. Maybe we can
Absolutely.
reconnect in 6 months and do another one.
Absolutely. I would love
Been
that.
too much fun chatting with you.
I love that. Thank you so much for having me on.
Thank you for help. Thanks for being
Thank you. Of course. Bye.
here. Happy Halloween.
Happy Halloween. Yes.
Thank you. Take care.
Bye.